understand that there is a different distribution of different electrolytes within the cells. So, Sayan, which are the major intracellular and which are the major extracellular electrolytes?
Intracellular will be potassium, magnesium, phosphorus, and calcium.
Okay.
And extracellular will be mainly sodium
and
enhanced will be chloride and bicarbonate.
So the most important one from the intracellular perspective is the potassium, along with phosphorus and magnesium, as you mentioned. What about calcium?
Calcium is mainly in the bones, 99% of it. And so apart from it, 1% will be in the circulation.
What about the cells? Is it more in the cells or in the circulation?
So more in the cells.
There is an active transport of calcium which happens inside, and that's very important because calcium is a major second messenger for a number of other processes in that perspective. So as we've discussed already, potassium is a player which is largely intracellular. Sodium is a counter player which is largely extracellular. And there is a big process which is there which really allows the transfer of this sodium and potassium, an exchange which happens in that perspective, and that's the sodium-potassium ATPase. So a large number of energy is actually spent by the body in keeping potassium intracellular and keeping sodium extracellular in that perspective. Now, we know in situations where keeping potassium in the cells is extremely important, and if potassium leaks out, there could be a problem. So what do you think are situations in endocrinology in which this potassium, if it goes out, causes a problem? So insulin secretion requires what?
It requires potassium inside.
So it wants the potassium channel to be open or closed? No. How is the potassium regulating insulin secretion? You're talking about the other way around.
It will close. Potassium will close.
Potassium will
Close. Potassium will close the.
What happens to the normal potassium ATP channel? We are basically looking into that. So one is the sodium potassium ATPase channel, and that's what you were saying is right, that insulin increases the sodium potassium ATPase activity, but that's a besides activity. Why I'm asking is that why is it important to maintain the intracellular potassium high from the insulin secretion perspective, Naveen?
Basically, the potassium is leaking, continuously leaking. Whenever there is a glucose or whenever there is ATP, this ATP will generally cause the closure of potassium channel, which will basically cause secretion of insulin.
So that potassium has to accumulate, that will depolarize the membrane, and then your insulin secretion happens. And that's the role of diazoxide, which is basically a potassium channel opener, which will allow potassium to leak, preventing the insulin secretion. So this balance of sodium and potassium is extremely important. And in a physiological perspective, it is the sodium potassium ATPase which plays the major role in that situation. And this involves the exchange of sodium and potassium. So potassium goes in, sodium goes out. That is the pretty much situation. Where else is sodium and potassium exchanged? So one is in the cell. Anywhere else, can you remember where sodium potassium is exchanged? So what is the cell membrane? Anywhere else in the body system? Which is important? Renal tubule. So whenever you want sodium to be reabsorbed, your potassium will be pushed out. So this brings you to a very, very fundamental sort of a simple sodium and potassium relationship. Any disorder with hyponatremia should have?
So hyponatremia should have
hyperkalemia. So there is an opposite relationship between the two. If your sodium is low, you don't have sodium for exchange to potassium, potassium will come out. That is one. And the tubular excretion will also be effective. So hyponatremia typically will be associated with hyperkalemia, and hypernatremia will be typically associated with hypokalemia. Now, this is also associated with the aldosterone action and other factors as well, but generally, sodium and potassium go opposite. As we say, calcium and phosphorus go opposite, same way sodium and potassium go opposite. If you have hyponatremia and hypokalemia, then it is an unphysiological situation, which means that you're losing both. You're losing both via the diarrhea, that is a gastrointestinal loss, or through tubules because of diuretic use or because of a sort of any ATN or a tubulopathy. If your both sodium and potassium is high, what does it mean? In which condition you will have both sodium and potassium high? So it's a very, very rare situation. It is one situation in which your epithelial channel is a problem. So in that situation, you will have both hypernatremia and hyperkalemia. But because of this reciprocal association of sodium and potassium, whenever sodium is low, generally you expect potassium to be high. And whenever generally your sodium is high, your potassium should be low in that perspective. Now, out of these sodium and potassium, which one is more regulated, Dr. Manoj, sodium or potassium? Okay. And you also have regulation for both hyponatremia as well as hypernatremia. So you have, for whenever your sodium goes down, we'll talk about that. In that situation, you've got the aldosterone system coming up. Whenever it goes high, you have the ANP system coming up. What about the potassium regulation? Potassium is regulated via which mechanism? Mainly via the renal system. Potassium is not regulated much. You don't have an exclusive, you have a salt retaining hormone. You have got the aldosterone, which is a salt retaining hormone. You have a natriuretic hormone, but there is no calciuretic hormone, or there is no particular hormone which will basically cause potassium to be there. Potassium is a byproduct. Whenever aldosterone goes up, now remember, when your sodium comes down, aldosterone will go up. Therefore, your potassium will be lost. So again, the same sort of a thing. It's a mechanism which is trying to increase sodium by decreasing potassium. Again, a reciprocal relationship. So potassium is hardly regulated. Therefore, if your renal function is defective, you will have a huge problem in terms of potassium. Sodium by far is the most closely watched parameter. Or if you look at other way, the tonicity, the osmolality is the most widely regulated. 1% change will make a difference. If you look at other parameters, if you talk about glucose, you're talking about a range, 80 to 140, you won't have much difference, but that is like 50% to 100% change. But sodium, if you go above 143, you will start having a change. So 1% change will start having a problem in terms of sodium. So sodium is very, very important for the body, more important than potassium, and this is what will remain important from a clinical perspective. Now, of course, we have discussed, this is what Manoj was talking about, that insulin pushes that, and this is very, very relevant in the setting of DKA. If your potassium extracellularly is high, that is basically because you have got a potassium which is being taken out of the cell. But if you give insulin, if you correct acidosis, this potassium will basically come in the cell, and that will also cause a lot of problems. Which other condition, hyperinsulinemia, becomes important cause of hypokalemia? Decay is one. What else? And you will have in that situation hypokalemia as well as hypophosphatemia. So when you are recovering from nutrition, if you talk about anorexia nervosa, or if you talk about severe malnutrition, you anyway have a potassium deficit. As soon as your glucose levels goes up, their insulin will go up and it will push. So major problem which happens in the treatment of severe acute malnutrition / anorexia nervosa, same phenomena, would be that you will have hypokalemia and hypophosphatemia, which will cause a huge problem. So insulin and beta agonist will cause the pushing of potassium inside. Beta agonist is more relevant from a therapeutic perspective when you talk about treatment of hyperkalemia rather than the actual physiological perspective. So we have talked about sodium and potassium as the major positive ions. What about the negative ions? And we all talk about chloride. So chloride is very, very important. Exogenous, the extracellular fluid, chloride is the major negative ion along with bicarbonate. But chloride will be like 100 in that perspective. Again, it is not there inside the cell. It's very, very limited amount of chloride is there in the cell. Bicarbonate again is largely extracellular, and chloride and bicarbonate, we've discussed this a lot, are the measured negative ions. And sodium is the measured positive ion. That is the basic thing. And then you talk about anion gap in that perspective. There are others, especially the protein, the negative anionic protein. We talk about albumin and other proteins which are there in the negative shape, which are largely responsible for the anion gap, which are typically around 10 to 12 in that perspective. Calcium, again, as I discussed, is largely an intracellular one, but extracellular plays a very, very important role in that regards. Phosphorus, again, is intracellular. One important thing to remember is that if you lose any of the intracellular ions, be it potassium, magnesium, or phosphorus, the other one will also be lost. So hypomagnesemia will cause both hypophosphatemia and hypokalemia. Hypokalemia will cause hypophosphatemia and hypomagnesemia, and the vice versa. So you have to remember that one intracellular ion lost, you will lose others because of whatever neutrality and other aspect in that perspective. So we've talked about measured positive and measured negative ion. The difference between the two is the anion gap, which we discussed a lot in the setting of RTA in the last session. Now, based upon that background, we'll now talk about two major ions today, the sodium and potassium, how they are regulated and how things progress from there. So when we talk about sodium, we are talking about two things. We're talking about tonicity and we are talking about volume. And in this perspective, we talk about sodium and we talk about water. Now, Sion, which is the major regulator of tonicity in the body?
Tonicity is sodium.
Tonicity is sodium. And volume is?
So, extracellular volume will be sodium, glucose, and a minor BUN.
So sodium is a major determinant of tonicity, but what is the major factor which regulates tonicity in the body? Is that sodium?
It is the ability of that specific ion to...
No, tonicity is a different thing. But I'm trying to say that you're saying right, that okay, sodium is equivalent to tonicity. But what controls sodium levels? Is this the sodium or the water?
Controlling of sodium level is...
Largely at the level of?
ABV.
Is at the level of water. So this is a confusing thing. Basically, what you remember is that sodium actually largely determines the volume. The more the sodium, the more volume will be having. And water determines the sodium or the tonicity. So when you talk about disorders of, in the sense when you talk about disorders of tonicity or sodium, they are disorders of too little water or too much water. It's all about volume. It's not about volume. It's about how much free water you have. So if you have too much AVP, you will have more free water. You will have hyponatremia. If you have too little AVP, you will have too little volume. You will have hypernatremia. So sodium disorders are largely disorders of water. And volume disorders, Naveen, too much volume, too little volume. When we talk about volume, we say hypertension. They are all because of sodium. So sodium determines the volume, and in a way, water determines the tonicity. This is something you need to remember, because disorders associated with more volume or less volume are more with RAS. And RAS is basically sodium, while water is mainly AVP, and that regulates sodium. So this is important to remember, that the major determinant of volume is sodium, the major determinant of tonicity is actually water, and through that ANP and RAS from that perspective. Now there are two mechanisms by which you will maintain your water. One is thirst. So if you are having less amount of water, you will drink. And the second is the urine output, which will basically regulate. Now this is again very, very important. If somebody has hypernatremia, what is more important? Decreasing urine output or increasing thirst? Which will help you correct your hypernatremia? So you stop urine output, will it increase your volume or not? Suppose your sodium is 180, you have stopped your urine output. In a whole day, somebody passes 1 liter urine. So you will gain 1 liter of volume, will it help you? You have to drink water. So that's what I'm saying, is that thirst is evolved as major defense against hypernatremia. Now, what you are saying is right from the perspective, we say that the first thing body does is that it stops passing urine. Of course, that's an obvious thing. You will stop your leak and then you will start drinking. Otherwise, you will drink and pass. But unless you drink, you will not be able to correct your hypernatremia. So thirst is the major defense against hypernatremia. If you go the other way around, if somebody is conscious and able to have good access of water, they will not develop hypernatremia. So patients, which patients with DI, therefore will develop hypernatremia? And infants, somebody with in the ICU, not able to get water. Third would be somebody whose thirst center is different. So if you have these three things only, then you will develop hypernatremia. Otherwise, DI will mainly present with increased water intake, polyuria, polydipsia. Now, what about if you have hyponatremia? Would you stop thirst? That is your major response, or decrease urine output will be your major response? Because that is very, very important, because the main response of urine output would be that if you have hyponatremia, or let's put it this way, you will increase the urine output. You won't decrease, you will increase the urine output. So the major response of hyponatremia is at the level of urine output. You will allow urine to pass, while there you want to drink more water. So major cause of hyponatremia therefore will be an abnormality in urinary concentration. You are inappropriately concentrating your urine when you should not, which basically means that everybody who has got hyponatremia, it is ultimately because of a AVP excess. This AVP excess may be appropriate or inappropriate, but unless you have AVP excess, you will not have hyponatremia. Now let's go one by one. Which are the major causes of hyponatremia that you have seen till now?
Basically, the one is the cortisol deficiency.
So in cortisol deficiency, will there be AVP excess?
Yes, sir, there will be AVP.
That is there because cortisol inhibits AVP, and we'll discuss about that. If you talk about combined mineralocorticoid and glucocorticoid deficiency, will the AVP be high? If your volume becomes very low, if you're losing around, if you become hypotensive, if you go into shock, vasopressin or AVP will go up. So again, there is a AVP excess. What else are the most common cause of hyponatremia is?
Basically, it could be because of third place.
So third place collection, will the AVP be high there? Because you have effective hypovolemia. So if you have liver disease, if you have nephrotic syndrome, if you have renal failure, you will have effective hypovolemia, and that's why your AVP will go up. What about diarrhea? Do you have hyponatremia commonly in diarrhea? Do you expect hyponatremia in diarrhea? What is the concentration of sodium, or what is the amount of sodium in the diarrheal stool? Is it less than the blood or more than the blood? It is usually less. So what you are saying that you're losing more volume than sodium. So diarrhea should theoretically not cause hyponatremia, but it does. Why? If you have hypovolemia, your AVP is more. Now, if you do anything inappropriate ORS, we are trying to say when you take dilute fluids, like you take water, you take something which is dilute. AVP is always ready to take this urine output. It is actually, you are not going to lose that free water. That free water will come into and you will develop hyponatremia. So if you think now, whether you talk about a diarrhea-related hyponatremia, whether you talk about cortisol deficiency, whether you talk about a mineralocorticoid deficiency, or the third space loss, all of them AVP excess is the primary problem. So hyponatremia is a primary problem of the lack of free water excretion. Hyponatremia is a basic problem with your thirst mechanism. Otherwise, you will not develop hyponatremia. And that's why hyponatremia is much more common than hyponatremia. Because to develop hyponatremia, only if you are not drinking water, which is very, very easy to do. This can happen at various situations. So definitely hyponatremia is more common than hyponatremia. This is what you will understand from that perspective. Now, once you have increase in your tonicity, there are signals, the osmoreceptors are there, which are in the periventricular region, which is the organ vasculosum of lamina terminalis and the subphonical organ. It will say, okay, our tone is increased, body is getting concentrated, we are getting dehydrated, the brain will shrink. So you have to do something. So what they will do from there is that they will produce AVP from there. And this vasopressin will basically say, okay, we do not want water to be lost from the urine. The free water excretion will go down and the volume will again increase and osmolality will come down. So the major regulator of osmolality, as I said, is vasopressin. And major problems of hypo and hypernatremia are AVP related. Now, if you talk about volume, to correct volume, you have to correct sodium. So for that, you will have the renin-angiotensin-aldosterone system, which will kick into the picture. And this RAS system will say, okay, I will decrease the loss of sodium. And whenever your sodium loss decreases, which all loss will increase, Manoj?
Potassium loss and
Potassium, proton, along with magnesium, along with calcium, all those things will happen. So you will have hypokalemic alkalosis. So a response to this sort of a conservation of sodium is hypokalemic alkalosis, which will happen. And that's why you have got this reciprocal relationship, which you will have in that perspective. Now, if your volume goes up, then also there is a mechanism. Your aldosterone will come down and your vasopressin will go up. And your natriuretic peptide will go up, which will basically be sensed by the cardiac receptors. And what does ANP do? What are the effects of ANP? And it will, what will it do in terms of aldosterone?
It will decrease the aldosterone.
So it will inhibit. So basically, it is not only causing natriuresis. If the same time your aldosterone is high, you will just negate everything. So it will suppress aldosterone. And therefore, we've got three mechanisms which are working together. And at the end, we'll discuss how these three have an interplay. And that's very, very important from a physiological perspective. How is ANP very, very important in somebody who has got a primary hyperaldosteronism? In primary hyperaldosteronism, what do you expect the sodium level to?
Sodium level we expect to be very high, but the body doesn't want increase in volume. So it will take away the action.
So as soon as your sodium level reaches a particular level, volume increases and ANP comes in the picture and it causes release of this sodium, and therefore you don't have hypernatremia in the setting of somebody who has got primary hyperaldosteronism. The major presentation is with hypokalemic alkalosis. What about ANP's role in SIADH? Do you think it has a role in SIADH? What causes hyponatremia in SIADH? So free water excess is there, and that free water excess is because of more AVP. Then what else happens?
then that is also causes the whenever there's an increase in volume.
So when your volume increases, your ANP goes up, and your ANP goes up, your sodium is lost, and your aldosterone is suppressed. So whatever sodium you will have, you will lose. So you will have further hyponatremia. This is very important to understand. If you give them saline, what will happen? If you have a SIADH patient and you give them normal saline, what is going to happen? You have got more ANP already in the system. Aldosterone is low. So whatever sodium you're giving is going to be lost in the urine. So there is going to be no benefit of giving sodium chloride in this setting. If you give 3% saline, it will act like an osmotic diuresis. It will take off water with it. We'll discuss this when we talk about SIADH in much more detail. So basically, ANP being high is one of the important contributing factors for hyponatremia and SIADH. So this is something you need to understand. So giving them more salt is not going to help out. That salt is going to be lost in the urine in that perspective. So this is important from that situation to understand. So let's go one by one about sodium handling in the tubule. So largely intestinal absorption, of course, you won't have much issue. It's easy. So major again issue happens in the kidney. So out of the maximum sodium that you get, all of it is filtered and around 97% is actually absorbed at the level of PCT. This is similar for many other parameters which we've discussed earlier. Out of the remaining 3%, 66% is absorbed at the level of the collecting duct and around 1% is actually excreted. So when we talk about fractional excretion of sodium, it is very, very low. Same as bicarbonate, as I said, only 1% is lost in the urine. So sodium is important for the body. They don't want unnecessary to lose sodium, only 1% will be lost. If, of course, you have got some problem in sodium resorption, there will be an issue. So all these sodium problems that we're talking are happening with this 3%. And out of this 3%, 66% is absorbed. Imagine if there was a proximal tubular problem which caused sodium resorption defect, patient will not even survive because then you're losing huge 97% is happening. But that is thankfully safe, or those disorders will not be compatible with life. So whatever disorders which you talk about are all in this collecting duct. And the most important final mediator of sodium absorption is the epithelial sodium chloride channel. And this epithelial sodium chloride channel is interesting because it takes sodium. It's basically a salt transporter. It is taking your sodium inside along with chloride. And it is influenced via the aldosterone through the mineralocorticoid receptor, which we already discussed. So this chloride is also absorbed along with this. But why does this result in the loss of positive ions, Manoj? You're taking out sodium, you're taking out chloride. Why should you lose a positive ion here?
But because sodium transfer is much faster than the chloride, so there is a electropositive charge inside the system. So it will secrete the potassium or H+ to maintain the electron.
So this is important. Sodium goes rapidly, chloride goes slowly. So your tubule is negative. So all the positive ions which are there, largely we talk about proton and potassium, but there is also magnesium, calcium, and all those things. So in that setting, they all will go inside. And this is what we talk about in the RTA perspective as well. So anybody who is having more conservation of sodium will basically be losing proton and potassium. Therefore, you will have hypokalemic alkalosis. But if this system is defective, if your epithelial sodium chloride channel or the mineralocorticoid receptor or the aldosterone is defective, what will happen?
So it will not absorb the sodium. So there is a hyponatremia with the
Hyponatremia, hyperkalemia, and acidosis. Alkalosis, not acidosis, and hypercalcemia. Because calcium is also not being absorbed, and hypochloremia. So you're basically losing salt, and because you're losing salt, you can't exchange with proton, potassium, calcium, magnesium. All those things will go up. So this is the hallmark of a RAS defect. The renin, angiotensin, aldosterone system defects will present you with hyponatremia, hyperkalemia, with metabolic acidosis, along with hypochloremia, with theoretically hypercalcemia, which may be relevant from a perspective when we talk about cortisol deficiency, which we'll discuss subsequently from that regard. So if you have got a sodium load, so if anybody gets a sodium load, you will lose proton and potassium. Is it true, Vibha? Why? If you give somebody sodium load, I'm saying that they will develop hypokalemic alkalosis.
Yes, there will be more sodium water exchange in the collecting tube.
So if your distal sodium delivery is more, you will have potassium and proton loss. And this is very, very relevant from the perspective of proximal RTA. This is what we discussed. In proximal RTA, if you treat them, they develop hypokalemia on treatment. Now, other thing I'm saying is that if you have high sodium deficiency, you will develop hyperkalemic acidosis. Why?
So if there is no sodium, then what is there to exchange?
So you can't. So if you have very, very low diet of sodium, you may theoretically increase your potassium. This is also an important thing to remember. If you have too much sodium, you will lose potassium. If you have too little sodium, you don't have anything to lose potassium. So ultimately, the king player is basically sodium. Based on sodium, your proton and potassium excretion and calcium excretion also depends. So if somebody has hypercalciuria, what would you advise them to in terms of the sodium intake? Increase or decrease? So hypercalciuria is the problem. You want the calcium excretion to come down, so sodium should be less. This is very, very important for RTA and other perspective that will help you out in that perspective. And thiazides are pretty much doing similar picture, and that's why you have got this picture in that setting. Now, we've discussed a lot about this epithelial sodium chloride channel. Now, this epithelial sodium chloride channel is within the cell of the collecting duct. There it is useless. It has to be pushed into the top of the membrane. And what regulates this push, Dr. Pratik? Which hormone pushes this epithelial sodium chloride channel up there? Aldosterone. So the only role that aldosterone does is that it increases the amount or the percentage of sodium that is there in the kidneys to be absorbed. So if your aldosterone is deficient, maybe you have 20% absorption. If it is there, you will have 60%. This I'm just talking about in a relative figures. These are not absolute figures. So as vitamin D, what vitamin D does is that it just increases the proportion of how much calcium that is there in the gut, which is absorbed from 25 to 40%. Same, the only role of aldosterone is to push the epithelial sodium chloride channel. What does it mean that if you have somebody who has got CH, some infant, and you're giving a large dose of fludrocortisone, but still the potassium is going up, sodium is not rising? What is happening? An infant with congenital adrenal hyperplasia is on 3 to 4 tablets of fludrocort, yet you have hyponatremia and hyperkalemia. What could be the possible reason? So there is theoretically, but this is CH. Why will you have aldosterone receptor defect? Naveen?
Adequate salt.
So as I said, if you don't take salt, and infant's diet don't have salt, milk has nothing, not much salt at all. So if you don't have enough sodium, how will that sodium absorption be increased? If you take 0, 80% of 0 is also 0, and 20% of 0 is also 0. So what you do is that you give them extra salt. That is why extra salt is very, very important for maintaining both sodium, potassium, and weight gain in CH in the first year of life. Once they become older, they will take more salt by themselves. Now, what regulates all that? And as I said, the major regulator of sodium is the RAS system. And the RAS system is therefore the major regulator of volume. Now, RAS system starts from renin. How does renin, where is renin secreted, and what controls renin secretion?
Renin secretion is controlled by volume, blood pressure, and maybe the potassium.
And where is it? Where does it come from? So it's in the afferent arteriole, just around that area. There are cells which are there. These cells sense the volume. You have said correctly. Blood pressure is a reflection of volume, so I wouldn't go much. So they look at volume, they look at potassium. And the third is, there's another signal for volume which is coming from somewhere else. One is coming via this macula densa, this region, you get it. Potassium, of course, is an important parameter. If you have a normal volume and hyperkalemia, renin will come up. The third is sympathetic system. So if you have hypovolemia, the sympathetic system goes up, and this sympathetic system will then be associated with increased renin activity. How is it important in terms of evaluation of the renin axis? Which drugs you should be careful about when you are evaluating for renin axis?
Any drug which blocks the RAS system.
Before that, I'm talking about something else.
Sympathetic blockers.
So anybody with any drug which blocks the sympathetic system will cause a falsely low renin. And sometimes beta blockers in specific situations can precipitate hyponatremia, hyperkalemia because of hyporenemia. Of course, if you're blocking distal, ACE, ARB, renin antagonists, they will all have a problem. But you should remember that beta blockers and other sympathetic blockers will also have a bad effect on renin situation. So this renin basically secreted in response to potassium and volume coming directly through the macula densa and indirectly coming through the sympathetic system will cause this renin secretion. Now we all know that renin basically converts the substrate angiotensinogen to angiotensin 1, which is then converted via ACE in various tissues. And remember, RAS is not just a systemic symptom. Every lot of small local areas, local tissues, kidney, there is also a local RAS. So there are different tissues will have their local RAS system working, but we are talking about systemic one. And lung is a major site where angiotensin 1 is converted to angiotensin 2. So the major product of the RAS system is angiotensin 2. So angiotensin 2 now, Naveen, is being produced in response to hypovolemia. What should it do to really respond to that? What all things should you think should do?
Basically causing increase in blood pressure, causes vasoconstriction, and also increases the aldosterone secretion.
Yeah. And
it also,
what are the ways you can increase your volume? So you said very well. One, I don't want to increase the volume, I want to increase blood pressure, which is the acute emergency. So I cause vasoconstriction. True. Second, you said you increase the aldosterone. Through that, the epithelial sodium chloride, you can do that, which is good. Any other way, which other mechanism will cause more volume? So you're talking about largely in the setting. You're talking about urinary excretion. You're talking about within that, whatever resources you have. So you're saying, I am not letting my volume loose from urine. One. Second, you are saying whatever resources are there, I am pressuring it out. So blood pressure is more. What else can you do to increase your volume? You can increase the thirst. So angiotensin also has an effect on the thirst. So you should remember that it's not just that they are just evolved like this. A single thing will do multiple things. And there will also be an effect on ANP. You don't want unnecessarily loss that ANP keeps on losing. That may not be a good for the body. So this angiotensin 2 is a very, very important player. It is one of the most potent vasoconstrictors which is there in the body. It will increase the blood pressure, it will increase the thirst, and it will say adrenals. Now you will start producing aldosterone. Now, what will be the first important pathway that will activate angiotensin 2? Which zone will it act and which pathway will it activate? And which will be the first thing which will respond to ANG2? Not receptor. You're going to produce more melanocorticoid, but how? Star. So the same star which responds to ACTH is also responsible for, because that is the cholesterol transport. So it will activate star immediately and say, okay, let's have a synthesis which happens very quickly from that perspective. Now, aldosterone may also have an influence from ACTH and AVP. Will it be a positive or a negative? But there is, that's what I'm saying. Is it positive or negative? It has to be, theoretically, it has to be positive, because ACTH again also wants to do the same thing. Ultimately, it wants to maintain your volume. So ACTH will stimulate, and AVP also stimulate aldosterone. What does it mean? Why would AVP stimulate aldosterone? Sign?
The volume contains.
So when your volume is less, AVP is more again. So these are all cross connections which are happening. So AVP also increases aldosterone. Now what inhibits is ANP. Now this is important. We talked about this. Your ANG2 will inhibit ANP, but your ANP will also inhibit aldosterone. So this is important. So whenever you are helping somebody, you will also like to block the somebody who is actually causing problems for you. If you have a friend, you're helping a friend, one, you are helping him directly. Second, by blocking his enemy, you will also help. So ANG2 not only stimulates aldosterone, it also blocks ANP. Because ANP blocks aldosterone. For ANP, it makes sense. I want the body to lose sodium. Then this fellow is actually saying, get more sodium, so I'll have to block him also. So that's why it's not an isolated thing. They will all interact each other. So what we're trying to say is that in the whole system, the potassium, the volume, and the sympathetic system are the major regulators. From there, you get renin, ANG1, ANG2 is a major player, and then aldosterone, epithelial sodium chloride channel, and sodium absorption. Now we all know that dopamine also will have an inhibitory effect in that perspective. So what will dopamine do to sodium? It will cause natriuresis. It will block aldosterone. So there is in certain situations, you talked about low dose dopamine. People used to talk about dopamine and dobutamine. They had a low dose infusions which were renal dose theoretically. They were based upon this, that this will cause natriuresis. Again, a confusing picture which we don't use any further in that perspective, and somatostatin blocks everything which we remember. Now, why I have put cortisol here is that cortisol, what does cortisol do to the mineralocorticoid receptor?
Normally gets deactivated, high doses will.
So cortisol and aldosterone, they are structurally similar for the mineralocorticoid receptor. For me, both of them are equally important. So what somebody is very huge amount, what I get is that I get somebody to eliminate that. So there is a sieve which is there in the form of 11 beta hydroxysteroid dehydrogenase, which basically inactivates cortisol. Because if we do not inactivate cortisol, there will be a huge effect of cortisol on the mineralocorticoid receptor, and you will have severe hypertension, hypokalemia, and alkalosis, and conditions associated with 11 beta HSD2 defect, which are known as apparent mineralocorticoid excess will cause havoc. They present in the infancy with severe hypokalemic alkalosis. And this is why 11 beta HSD becomes important in that regard. Now, this is inactivated as we discussed. So this is what we talked about sodium. If you understand that, now you will understand very simply that if you have any problem in the sympathetic system, in renin production, in the ACE inhibition, angiotensin receptor blockage, aldosterone production, in the mineralocorticoid receptor, or at the setting of the epithelial sodium chloride channel, you will have hyponatremia with hyperkalemia, with metabolic acidosis, with hypercalcemia that will happen in that perspective. So we have talked a lot about sodium. What about water? And water is the major determinant of sodium, we said. Now, water again is filtered a lot, and that's why we see so much water is a major component of the urine anyway. And out of which, whatever resorption happens of the water happens at the level of collecting matter. And this resorption is largely active because your membrane is really resistant. It doesn't allow water to go out. So what causes this active transport? So V2 receptor causing the aquaporin channel. So you basically need a special channel which goes to the membrane and makes it again permeable. Again, the same mechanism. Vitamin D, D-binding protein, which goes outside and gets the calcium binding protein and gets calcium inside. The epithelial sodium chloride channel being pushed by aldosterone. AVP pushes the aquaporin to get the water inside. So these are specific channels which will allow water to enter from that perspective, and this becomes important from that regard. Now we all know that AVP is a unique hormone, that it is actually being produced in the hypothalamus and then gets stored in the posterior pituitary. It is produced by the supraoptic and paraventricular nuclei. They all converge at the level of stalk and then they enter the posterior pituitary. Around 5% of these neurons terminate at the level of median eminence. So for DI to happen, you would need to have a lesion which is above that. Just a pituitary lesion will never cause diabetes insipidus. This is something which we have discussed earlier also from that regards. Now, from the magnocellular ones, which are the major neurons, you have got AVP, which regulates the water regulation from that perspective. And from the parvocellular, it regulates mainly the ACTH release, which again is important. So AVP stimulates cortisol release. What would cortisol do to AVP, Manoj?
Cortisol will inhibit AVP.
So that's a feedback mechanism. It increases, that will inhibit. So in cortisol deficiency, you will have? You will have SIADH. That's why in SIADH, you have to always exclude cortisol deficiency. In cortisol deficiency, in a patient with DI, what will happen?
AVP will be increased, so there is a increased resolution of the lesion.
So low AVP, high AVP, you will have 0. So you will have resolution of DI. So if you have a patient who is long-standing diabetes insipidus, suddenly the urine output becomes normal, develops hyponatremia. Think of an evolving cortisol deficiency, and once you treat, they will improve from that perspective. So DI will happen. Now, what you're seeing here is that the neurons are very widely distributed. If you have a hypothalamic lesion which is causing DI, it has to be large, something like a craniopharyngioma or a surgery or a diffuse brain damage. That is only going to cause DI. If you have a small lesion at the stalk, it can theoretically cause DI. But if you have anything below the stalk beyond which neurons are not at all terminating, it will never cause DI. So the presence or absence of DI really distinguishes between a pituitary lesion versus a supracellular lesion, which we have discussed a lot. The other parameters is that if you have an early ocular involvement, it will suggest that it is mostly a cellular lesion, while late will suggest a supracellular lesion in that perspective. Now, AVP is largely regulated by the level of osmolality, and there are multiple factors which affect its regulation. And we all know that the major regulator is the plasma osmolality. Its main role is to control osmolality. So if your osmolality is less than 280, you will typically have 0 AVP. And as it increases from 280 to 283, it starts increasing. And by the time you reach around 295, you will have maximum AVP. Now, what does it mean? what would be your target level of overall water deprivation test? What would be your target osmolality you would like to achieve? Yeah. Should be around above 295, and that's why we use 300 as a cutoff. So at 300, your AVP should be maximum. At what level is AVP minimum? 280. So that's why we use 270 as the cutoff for SIADH, and we use 300 as a cutoff for DI. So as you see, you can say 280 and 295 may also be there. But at 300 also, if somebody is not concentrating the urine, there is a DI. If at 270 also somebody is concentrating the urine, that is SIADH. So this curve really tells you that you should have no AVP below 280. If you are having something below 270, there is definitely pathological. You should have 100% AVP beyond 285, 295. If you don't have any at 300, it is definitely pathological. So this is what you need to correlate in that perspective. It's highly sensitive. 1% change will make a difference. And the set point may be altered in certain situations, like
the pregnancy and during the luteal phase.
So LH is a major regulator in terms of the set point. Now what LH does is that it shifts it towards the left side. So in the luteal phase, as you said, or in pregnancy, because HCG is working like LH, your sodium cutoff will become low. The body will like to maintain sodium maybe at 130 rather than 135. That's why you will have edema, you will have some fluid overload, which will happen in that perspective. This is important. And if you have hypovolemia, so I said the major regulator of AVP secretion is osmolality. But there is also a big overrider, that is hypovolemia. But this hypovolemia has to be significant. If you lose 15 to 20% of volume, which means that basically you are in shock, severe shock, then only this vasopressin will come. And then this vasopressin will be many times above the normal range. What is the dose of vasopressin we use for management of DI infusion? Acute DI infusion, what is the usual dose?
0.1.
So 1.5 milliunits per kg per hour. What is the dose you use for hypertension? Severe shock, we use vasopressin. The dose is very time higher. So vasopressin is the same. AVP and vasopressin are the same. But the pressure effect requires much higher dose, while the antidiuretic effect requires much lower dose. Similarly, the vasopressin secretion for volume comes only if you're 20%. But the other way around is that if somebody is hypovolemic, they will produce more AVP for that particular level of sodium. So if your sodium is 140 and you are euvolemic, and your sodium is 140 and you are having 10% dehydration, you will produce much more AVP at that point of time. So this is something you need to understand. So this is like a second regulatory. Major regulator, of course, is the osmolality, which is there, which regulates in that perspective. Now, this one is very, very important in terms of what happens to plasma osmolality with AVP. So as we have discussed is that as your plasma osmolality increases, the AVP increases, the urinary osmolality should also increase. So if somebody's plasma osmolality is less than 270 Manoj, what should be their urine osmolality? Less than 100. If it is more than 100, it is? And what will happen if your plasma osmolality is more than 300?
Then urine osmolality should be high.
High means what?
It is more than 600.
Should be more than 600. Otherwise, you will have diabetes insipidus. So this relationship, again, this curve will tell you the same picture. So if you have somebody who is actually having concentration, if you give them AVP, will their osmolality increase further?
No.
Because you're already at a high level. How much more will you respond? If somebody already has maximum glycogenolysis, hypoglycemia, if you give them glucagon, you will have no response. But if you have insulin excess, they will respond. Same thing here. You already at a peak, what more AVP will do? But if you, so this is a normal response. What about this response? Your plasma osmolality is increasing, urine is not. So this is GI. You give AVP, it increases like this. So this is a complete central DI. Here, there is no response. This is complete nephrogenic DI. So this is how you will respond to that. Now, if your free water has a change, there will be different response which will happen. If you have got more free water, what will happen to AVP? Vibha?
So more free water.
Fluid is more, AVP should be decreased because you want to excrete the free water. But if your volume is less, you will have more AVP. This is a normal response. So normal response is that if you have got more water, AVP should become less, excess free water, urine osmolality should be less than 100. This is what Manoj was saying. But if it is more than 100 and your osmolality is less than 270, this is SIADH. If you have got less volume, your AVP should be more and urine should be concentrated. If you have got a free water deficit and still your urinary osmolality is less than 600, this is DI. So whenever you look at plasma and urine osmolality in totality, you will know which way you are heading forward. So this is what we discussed a lot with regards to the overall aspects of sodium homeostasis, and this will be relevant. So if you now understand simply what could be the potential causes of hypo and hypernatremia, and once we discuss this, it becomes much easier for you to identify. So what will cause hyponatremia sign? What conditions will cause hyponatremia?
One is excess free water. Second is losing sodium. Now losing sodium can occur by the GI tract or by the renal.
So which will be more important?
So increased free water will be more important.
So you can have increased free water.
And losing sodium from the.
So increased free water will be more important in that perspective. So now let's go one by one. So if you have got increased free water, the conditions would be cardiac failure, nephrotic syndrome, or liver disease. Other causes of increased free water would be
SIADH.
And
Cortisol deficiency.
Cortisol and thyroid deficiency. And that's what we say, that if you have SIADH, you have to exclude those as a possibility before you do anything else from that perspective. Now, let's go the other way around. If you have got free water excess, you are causing hyponatremia. Free water deficit will cause hypernatremia. So again, the major causes of sodium disorders are here. They are free water problems. So free water deficit will be there. In what setting free water deficit will cause that? So if you're losing water which has got lower concentration than the serum, you will develop that. So that could be in the setting of diarrhea. So that's why we said diarrhea should actually cause hypernatremia. It causes hyponatremia if you're drinking water. If you're not drinking ORS, then AVP is there, it will push it inside. If you have hyperthermia or sweating, you will again be losing free water. That's going to cause hypernatremia. Now, diabetes insipidus will also cause free water loss. That will be osmotic. Now, from the sodium perspective, so we talked about water perspective. What about sodium perspective? What are the sodium perspective will cause hyponatremia? So RAS defect. So RAS defect will include what all? Which will basically mean if you have a problem of hyporenism, you have got a ACE inhibitor, angiotensin receptor blocker, or there is a congenital adrenal hyperplasia, adrenal insufficiency, aldosterone deficiency, aldosterone deficiency, all those things, and the epithelial sodium chloride channel. Tubulopathy will be other thing as well. You're losing water as well as sodium. But in both these conditions, your AVP will go up. And that would also cause hyponatremia, which will happen from that perspective. And of course, diuretic will be the same thing in that regards, as will be salt wasting. Which conditions from here will cause sodium excess? So hypernatremia, can it be because of sodium excess? Theoretically, no, because as soon as your sodium goes up, your ANP will come into the picture. So there will be more of hypokalemia, though RAS excess will not cause hypernatremia. So as I said, hypernatremia is mainly free water deficit. Hyponatremia is largely free water excess, except for some of these tubulopathy. There also you have got more AVP which is coming into the system.